I want you to move from overwhelmed by information to confident in what really matters. I want to help you move from being unsure towards direction and purpose in your healthcare. I want to introduce you to health experts. I want to let you in on tough conversations on women's health. I want to give you a place where you can lean in and learn how to take care of yourself. Let's transform your health. Let's get clear on your goals. This is Women's Health Unplugged. I'm your host, Dr. Jordan Robertson, naturopathic doctor. Welcome to another episode of Women's Health Unplugged. I'm pretty excited for my guest today. Hi, Dominika.
Hi, Jordan.
Dr. Dominika Zarzenzny and I have worked together for a long time. We're past the 10-year mark, I feel like.
We are.
And Dominika, the reason I wanted to have you on the podcast today is because your skill set, your background, your knowledge, and your ability to work with women and people is so different than mine. And it's one of the things I've always appreciated about our working relationship is that you've had this background, interest, and pursuit of higher education and supporting people through stress, through resiliency, and through how stress and trauma impact their health. Can you just walk us through how you got to this place in your career and introduce yourself for the audience?
Yeah. Thank you for that. So I started my career off, my training, like most of our colleagues, which I got a bachelor's in science with a focus on genomics, which is a focus on genes and proteins and how they relate to disease. And about 6 years into my practice, I stumbled on a study that literally floored me. And it took a moment for me to get my bearings. And then at that point, I realized that I really needed to rejig my clinical toolbox to account for the discovery that I had made, which I'll share with you in a second. And then it was from that point on, which was 7 years ago, that I dedicated my practice to understanding how the state of the nervous system influenced and continues to influence a patient's health. So I furthered my studies and training with the various psychologists and experts in the field of psychological trauma. And a lot of my training was not only didactic, but it was also practical. It meant that I too was invited to look at, get curious, explore, process, and integrate my own life story and my life experiences. And that part of my training really made me feel comfortable to do the same with my patients. So I incorporate the principles of neuroscience, attachment theory, polyvagal theory, mindfulness into my compassionate inquiry with patients and my counseling. And I've come to better understand the role of the nervous system in how it plays out in mental health and chronic disease. And that particular training and continuing education has really helped me support patients in their health journey.
So I think, and I probably used the wrong language there because I said trauma. And I think it's really common when we start to talk about stress and trauma that either we normalize the level of stress or distress that we have in our lives, or we don't see our experiences as being traumatic. Again, either we've normalized them or we have a particular definition of what we think childhood trauma would look like, right? We maybe have a vision of someone, on the street in absolute poverty with nothing to eat. And we can easily go, well, that's not me. So therefore my experiences are not at that level to cause maybe the dysfunction that, Jordan and Dominika are talking about. But we're actually probably talking about almost everyone when we talk about this concept around early stressful events and then how it influences health.
Yeah, I think we're moving away from our understanding that the word trauma is to be reserved for war veterans, for people who have come from war-torn countries, or anyone who's experienced a natural disaster of some kind, which are single traumatic events. But when we're talking about trauma and what the research is telling us in the areas of neuroscience and psychology is that traumatic events is not so much an event itself as much as what happens to the nervous system as a result of the experience that the individual has had. And what we know about trauma is our early life experiences have a disproportionately impactful effect on shaping our biology and our health over our lifespan. And so when we're talking about trauma, that's what we want to be thinking about. We don't want to be thinking of it as an event, but what happened to that individual as a result of the situation. And those situations, particularly when we're talking about children, are talking about situations where the stressor is prolonged, repeated, intense, and inescapable for kids. So while there are the major traumas that we can think of, like alcoholism, domestic violence in the home, and poverty, it doesn't have to be a trauma to that extent. There are traumas that happen at the level of the caregiver and child relationship, which we call attachment traumas, that can leave a child's nervous system feeling dysregulated. And if that goes on dysregulated for a prolonged period of time, that could have impact on their health, both mental and physical, over their lifetime.
And so the lens that I want to look at this from is, our 30-something to 60-something women, not necessarily thinking about their children, right? Like that's not the angle that I want to look at it from. I actually want to think about those women as children and the impact that those experiences have had on them. But can you give some examples? Like if it's not those big major traumas, like what does that look like on a more subtle level of the kind of experience we maybe would have had in our family?
Yeah, so you're bang on that, the patients that come to see us, the women that come to see us, more often than not, what I'm hearing are things like anxiety, low mood depression, insomnia, autoimmune disease, difficulty in losing weight, and then anything that's hormone related like PMS, PMDD, and even like just severity of perimenopausal and menopausal symptoms. And when I do screen patients for early life experiences or traumatic early life experiences, they don't have too much to report. And so I start to ask them, well, if we were to look at the constellation of symptoms that you're having, what's the common thread between the insomnia, the anxiety, the difficulty in losing weight? And they take a moment, they reflect, and they come back and they say, I think my nervous system is playing some kind of role. And they're bang on. There is, when we're talking about a stress response, an activated stress response, we're talking about a dysregulated nervous system that downstream from there is affecting cells, tissues, organs, and organ systems that then look like symptoms or conditions that they're presenting with. So I'd love to touch on the ACE studies in a second, but to answer your question, it's attachment trauma that we want to be looking at is, and I really don't want to necessarily be conveying a message that childhood is about Pleasantville, rainbows and butterflies, but it is about when there are moments that are difficult in childhood, that we want to have a reparative opportunities. So children know from very, very early on that their ability to survive is dependent on that emotional bond or that attachment with their caregiver. And they will do everything that they can to ensure that that connection, that attachment is secure. And so what happens is when a child is experiencing their parents arguing or their parent yelling, that child will feel frightened. And in a perfect world, in a secure attachment, that the upset parent will take that child aside and say, I'm sorry that I yelled. It's okay to get angry. It's not okay to yell. And I'm sorry that you're frightened. And that child is met. Those feelings are validated. And then that you've repaired that connection. And the reality is that, parents, and we're all, it's not about being perfect parents. We can feel at times unsupported, impatient, frustrated, stressed. And so we can't be that nurturing, responsive, consistently present parent that we want us to be. And so we want to have moments where we repair that connection. But if that doesn't happen on a repeated basis, that child is left to internalize those emotions. And internalized emotions basically means I have nowhere to go with these emotions, and I'm left to have to figure them out myself.
And are we seeing a generational like change or like what's happening generationally with all of that? Like I think back to, experiences where there was never repair, right? Like you get in like a huge like blowout and then everybody goes to the mall
Yes.
10 minutes later, right? And it's like, are we fighting? Are we not fighting? Are we? But I do think there was the theme, and I'm going to go one generation back and maybe two generations back of like, first of all, suck it up. Second of all, mental health doesn't matter or it's a choice,
Right.
right? And third of all, I don't think we placed a lot of emphasis on the the nervous system regulation of children. We just call children resilient,
Yeah.
right?
Well, all children are resilient, and they get to be the adults that they are because of that innate resilience. And I think probably the most harmful proverb that got incorporated into our culture is that children are to be seen but not heard. Because when we believed that as children, it meant that whatever we were experiencing internally, we couldn't express that. We couldn't go to anybody with that. And that is probably the most harmful proverb that could have ever entered our culture. And I think generationally, you and I having children, we're realizing, you know what? Mental health is not about the absence of a formal diagnosis. Mental health and wellness is about being able to be resilient. It's being able to be able to bounce back from challenges efficiently and not stay in that place of dysregulation and distress. And another word that I want to incorporate here is building self-efficacy, which is I know how to help myself when I need to help myself. Those are two, I think, such important building blocks when it comes to mental well-being, that mental health is not about the absence of disease per se.
So like looking back or trying to figure out, so now I'm guessing that a listener is going like, well, I don't know if I had attachment trauma now that I think about it, right? Like it felt normal at the time.
Yeah.
Like, are there signs that either as adult children, we can look at our like current dynamics with those caregivers to say, oh yeah, like this is a thing. Like I can see whether it's narcissism or whatnot, like, are there ways to like look back on the past and see those flags?
Well, I would say that we've been in practice now for 13, 14 years. I can confidently say that in every in every case of mental health or chronic disease, there is an element of trauma at its core. That's just what I've seen. And the trauma that we're talking about in the absence of something very serious is around attachment traumas. And so the way that we know as adults that we're stuck in a loop of a certain type of belief or narrative about ourselves is, and this quote I really like by Ryan Marcus, and it's every upset is a setup. So it's one thing to be driving on the highway and get cut off by a car and be like, oh, that driver wasn't careful, and be angry about. That's a legitimate reason to be angry. It's another thing to be cut off, get angry, and then start to create a story or interpret that situation as, see, that's what people do to me. They cut me off, and I bet you when I get into work today, my supervisor is going to give me a hard time. And while I'm at it, my husband hasn't called me today, which makes him, unsupportive of me, and I'm not seen, I don't matter. That's how we know there's something to look at a bit more closely. And that's from the affect or emotional standpoint. We also want to be looking at physical symptoms. We know that women who, the more stress that they're experiencing when it comes to things like PMS, the worse their PMS symptoms. Now, if we look at why that may happen, we know that the menstrual cycle is made up of two halves. There's the follicular phase, there's ovulation right in the middle, and then the second half of the menstrual cycle. That second half of the menstrual cycle is one of sympathetic activity, and that's by design, to encourage and favor embryo implantation. And when we say sympathetic activity, we mean that that direction of fight or flight. Now, if I'm experiencing mental emotional stress in the second half of my menstrual cycle, at a time where I'm already in that sympathetic overdrive, well, I'm now going to experience the mental, emotional, physical symptoms far more intensely than when a woman who's not necessarily stressed. And early life experiences, challenging ones, have been shown to increase the risk for having really severe PMS symptoms. So we want to be looking at what's the patient coming in with, and let's see if we can follow the breadcrumbs back to what may have happened in their early life to leave them feeling like their nervous system dysregulated, and it presenting the way that it is with respect to symptoms and health condition.
Oh, I have a lot of questions now. But what I wanted to pick on first before we dive in is you're making that statement like nervous system dysregulation. So we have like that term, and then we have the term stress.
Yeah.
I think it's maybe worthy of like just differentiating between the two, because I think we throw the term stress around pretty loosely.
Yeah.
And sometimes we mean nervous system dysregulation, and sometimes we don't. Like, can you define those two things?
Yeah. So stress, and I've actually dropped the word using stress, and I've been replacing it with nervous system dysregulation, because stress is just the demand that's being placed on us. And we don't always have the luxury of changing around the demands that are placed on us, whether they're family demands, work, so on and so forth. But what we want to get really curious about is the state of the nervous system in the face of these demands. And so I've made it a point to use nervous system dysregulation to describe what is happening to the patient when the demand is high. Now, when we're talking about nervous system dysregulation, and when I say the nervous system, what I mean is the autonomic nervous system. It's the part of the nervous system that's under involuntary control. It's operating automatically in the background without our conscious input. And usually we think of it as two different branches. We think of it as the sympathetic nervous system, which we colloquially termed fight or flight. And then we think of the parasympathetic nervous system, which is rest and digest. And I'm going to say here to clarify that there's actually three branches to the nervous system. And this is really, really important, because part of the work that I do with my patients is to help them map their nervous system state. Because although it's under involuntary control, when they start to track their symptoms and bodily sensations, they can be like, oh, I'm in sympathetic overdrive, and then I can use the necessary tools to get myself out of here. So the autonomic nervous system is a tripartite system, meaning three parts. There's the sympathetic nervous system, which is about mobilizing our resources. It has this moving. And then there's the parasympathetic nervous system, and it has its two branches. One is called the dorsal vagal branch, and then there's the ventral vagal branch. And I'll get to that in a second. But we often think that it's one system is on and one system is off. And in fact, they're always on, but one will have greater activity than the other. So we want to be thinking of the sympathetic nervous system as the gas pedal, and the parasympathetic nervous system as the brake. And so if you're driving on a busy city street, your foot's always toggling between the two. Okay, it's when our nervous system, which is subconscious, we're not even paying attention to it, if it starts to detect danger, it's going to activate that sympathetic nervous system. And that's the fight or flight that we're talking about. So fight, meaning you lean into the danger, and flight, meaning you lean away, you want to escape from it. And in this state, you've got capacity. And what we see physiologically is an increase in blood pressure, an increase in heart rate, an increase in circulation to vital organs like the heart, brain, and muscles. We see increased oxygen capacity and increased defense responses. And what we see actually decline is digestive function. So in that fight or flight response, people will often have symptoms of constipation, as an example. Okay. And what is, so in addition to digestion decreasing, you also have your immune system is suppressed, and that's all by design. But we're never meant to stay in that sympathetic overdrive. We are there for acute stress responses, and then we're meant to come down, rest, repair, and then go on. So that's the one state that I want to shed light on. The second one is that parasympathetic dorsal vagal system, which is about, when it's not activated, is responsible essentially for our digestion. So everything is moving smoothly, both literally and figuratively. When we get really stressed, when we see the danger as a potential threat, that's when the freeze response comes in. And that looks like an immobilization. From this place, I don't have capacity. And what that looks like physiologically is a drop in blood pressure, a drop in heart rate, a drop again in immune function and our defenses. And we're not actually, we're the energy stores here that have been mobilized, we're in a frozen state. Okay, so that's that second freeze response that people are really familiar with: fight, flight, freeze. And then that third one that we're talking about, that ventral vagal response, that's actually a place of connection. What you and I, Jordan, are doing right now is we are in our ventral vagal state. We are connected, we're grounded, we're settled, we're able to collaborate, communicate, put our heads together to come up with solutions to problems, so on and so forth. So we want to teach our patients to flexibly toggle between states. It's when we get stuck in a perpetual state of fight or flight or freeze, that's when we get into trouble. Because the very state of being in sympathetic overdrive or in freeze shutdown is in and of itself inflammatory, and if prolonged, is what increases our risk of developing mental health and chronic disease. So we want to train our patients to be able to self-regulate.
You can start to see how the way that you see the world starts to influence your ability to like move through those pieces, right? So if you think that the world is a dangerous, scary place and everybody's out to get you, you do start to see that driver in that way. You are pretty sure that your boss is going to rip your head off.
Exactly.
And then you can't move into that state of connection, right? Because you're in that like almost like wired state. You're going to see everything from that lens. Is that how it works?
That's
Is that right?
That's exactly how it works. So you're either in connection or you're in protection. You can't be in connection together when you're in a state of protection, right? So when you're in a state of protection, now your entire nervous system is looking for and expecting danger, which means that you will misread situations. You'll misunderstand and read into things that people have said that may not have said what you think that they have said. And so now you're becoming hypervigilant, and your beliefs start to dictate your behavior. And that's really important. We want to be thinking of how are you navigating the world from a psychosocial standpoint, which is you're hypervigilant, you're expecting the worst, and your body is also following suit and showing signs of being in a state of fight or flight or freeze.
Does that show up in people's ability to maintain their health habits? Like, just trying to think of like a topical example. Like, I imagine that at being resilient enough to like make your lunch every day, you know, and take it to work is impossible, because if you run out of turkey on day 4, like you actually can't, you know, just slide past that obstacle that easily. Like, I imagine that it's actually starting to show up everywhere for patients.
It shows up everywhere. So why I love that we're having this conversation is I want us to take the pressure off of the patients who think that they're not implementing the right the good health habits because of lack of willpower or inability to stick to a plan. Okay, this is by design. If you are in a stressed state, you not only can't be creative in terms of your lunches, you can't see past end of the day, right? Because in order for you to be able to plan, self-reflect, monitor your progress, that's a higher brain function activity. And higher brain function activities like our left brain hemisphere is responsible for, you know, three things that start with the letter L: language, linear, and logic. Well, that part of the brain is offline when we're in a perpetual state of stress. So what I want to tell patients is, it's not your fault. You weren't born this way. This isn't something that you've done to yourself. This is an adaptive neurobiology designed to keep you safe, except that it was designed to keep you safe at a time where you were vulnerable. And now as adults, we want to be able to harness their resources and shed light on, actually, you do have capacity to take care of yourself and keep yourself safe, whatever that looks like.
I find this I love this conversation, and I've done some cool reading and listened to some great podcasts talking about specifically mental health in men, and around that whole repair aspect of attachment in young boys versus their male, caregivers, and how that has been a setup. But I love expanding the conversation, just looking at all people, right? Because I think, I want to come back to something you said there that I feel like is really valuable. You said that it's not about clearing the deck from their schedule. It's not about clearing their schedule as far as getting better. And I think, can we talk about that a little bit? Because I do think sometimes when we talk about how stressed people are, and I'm saying that in air quotes, that even as practitioners, sometimes it feels like the solution is okay, delegate, let's get some shit off your plate. How do we help you here? Where that, now that I'm thinking about it, that might actually not be the right idea.
Yeah, I think what happens is when we start to run on autopilot, that autopilot, which was a program that we probably created a long, long time ago, like keeping busy, like keeping your head down and doing the thing. Well, when we're on autopilot like that, we're not really tracking ourselves. We're not tracking that, you know what, I've bitten off too much, more than I can chew. And maybe it is about delegating. Maybe it's about resting. Maybe it's about, rejigging our schedule or clearing, but we have no way of knowing what the right solution is if we're not being mindful of what we're doing. And so there's really interesting literature by a study by Dr. Kessler that compared the impact of relaxation versus mindfulness. So mindfulness is an awareness from moment to moment of what's going on inside you and outside of you, right? Which is not actually about relaxation. In fact, much of my mindfulness meditation practice is about uncomfortable emotions or uncomfortable experiences. But what that study looked at, and I think it was a 12-week study, that after 12 weeks of a relaxation practice, the participants did not actually show improved inflammatory markers. They didn't even have improved results on things like well-being and mood or anxiety or perceived stress, versus the group that had practiced mindfulness for the exact same amount of time had improved CRP, cytokines, as well as a sense of improved well-being. So it is about the mindfulness piece more so than relaxation. Because the thing with relaxation, and something that I see in my patients all the time, is that they're engaging in short-term energy releasing behaviors. The acronym for that is STIRBs. So they're coming up on the end of the day. They are wired but tired. They don't know what to do with that. So then they start to have a glass of wine, scroll social media, online shopping, maybe continue to do work. Any kind of behavior that relieves temporarily a sense of discomfort, but it's really not getting you any closer to figuring out what you really should be doing for yourself.
It's more like numbing, right? Is that a good term for it? Yeah, because when I think about those behaviors, I do think of them as just procrastinating on the real work.
Yeah, I'm checking out, right? So we never, what I do is I want to get curious about the behavior. What STIRB are you engaging in? What's your unique STIRB? And then what's the impulse? What's the feeling? What's the sensation that leads up to the behavior? Because if we just say the behavior that they're engaging in is bad, well, they're just going to find another, perhaps more socially acceptable behavior like eating versus alcohol to swap it out with. Whereas I want to get curious, well, why are we engaging that behavior to begin with? What's the state that you're finding yourself in preceding engaging that behavior? That's what I'm curious and explore with my patients.
It's so fascinating. And as, of course, as you're talking, I'm like trying to think deeply about my own personal situation. It's funny, I was telling my daughter a story because we'd driven by my parents' neighborhood recently. And I was like, see that crabapple tree there? I was like, I used to sing songs to myself about all the things I would say to the bullies to that tree before the bus picked me up. And Charlie was like, well, why wouldn't you, like, she said, why wouldn't you just tell your mom? Right? Like her automatic response was like, why are you telling a tree? Like nothing but that was one of my coping strategies during that time of my life, was that I would say it all. I would just say it like to the tree before I got on the bus and zip my lip, and then just endured all of the bullying. And it's interesting because I have seen, and I've worked with my therapist a ton on this, is like, I have seen aspects of that, like rehearsal, right? The rehearsal of the conversations persist into my adult life until I like really looked at it and was like, shit, like I waste a tremendous amount of time trying to practice what I'm going to say to all of these people. I'm getting nothing done, right? Like I just need to put that down. But it's funny because I never really had thought about it in such a negative light. To me, it was like almost a fond memory that I had been singing songs to this crabapple tree about the bullies. And it took my daughter being like, well, that was dumb. You should have just like told someone about it.
Yeah. Which tells us that it's not so much the event as much as what happens after the event, right? So if for the majority of us who've experienced moments, particularly when we're young up until the age of 18, which is when, in those formative years when our nervous system is developing and we're figuring out ways to regulate ourselves, it's not so much about the bad situation that happened, is who do we get to tell what happened, right? So if I remember, in terms of my life story, there was some mental health issues in the family, and I spent a good portion of my childhood really frightened. But who was I going to tell? My parent who was suffering from depression, or to my other parent who was in great distress trying to manage the day-to-day life, whose spouse was depressed? Like I wasn't going to burden either one of them with my fear, so I internalized it. I just kept it to myself. This is just something that I have to figure out on my own. And that belief that my big emotions, my scary emotions, are mine to take care of, well, I took that into adulthood, and that presented as a combination of anxiety and IBS. And so it's not about not feeling frightened. Those are the normal and expected emotions. It's having a loving caregiver to meet you in that place and validate your experience.
We talked a little bit before we hit record about the difference between, like, we talk about mental health as like feeling good versus being good at feeling. And I feel like that's such a profound quote. And really, like, as a practitioner, that's what our ultimate goal is with patients. And sometimes we can get like tripped up in the, we want to give you this and it'll bring you more joy, right? Like here's a supplement or a medication and it's a happy pill, when really it's just like the absence of sad pill, maybe. Maybe better termed.
That's
like
right.
it's like a not sad pill, but it's not a happy pill. But really that's not what we're going for, right? Like it's not that we're not saying that there's going to be no stress and no bad days.
That's right. Are you seeing the world and yourself in it as a place where I can navigate the challenges and I can navigate the problems with ease, and I know how to resource myself and I feel resourced in that place, versus living in a world where it just feels like one problem after the next that I'm just juggling and dodging like a landmine? Or are you living in a world where you're damned if you do, you're damned if you don't? Like this is just, it's a bleak place. So you're right, and it's a quote that I heard, and I can't tell you where I heard it, but it's not about feeling good. It's about getting good at feeling. Because when we get really clear on how we're feeling, then we come to a place where we can choose how to respond versus reacting. And when we're reacting, we're not at the wheel. We're just then running on autopilot, on impulse.
So one of my challenges with looking at this topic of like early childhood events and then attachment trauma has been that it's felt like that was a little bit of a like this like non-modifiable thing that was in someone's past. And so I asked about it like as a clinician and even thought about it myself. But I even remember when my therapist brought it up, I was like, whoa, don't bring on this like childhood trauma shit with me, because I'm like, what are we going to do about it? Who cares? Like, let's talk about my work deadlines next week. But I think the research has shifted in such a positive way to discuss like how we support the adult person in recalibrating their nervous system, and that you can heal from it. So it's not this like, you know, we're doomed if we had these early childhood events. There's some like ways to resource patients and get them like an active part of that process. Where do people start? Yes. Like, how do we start that process?
Yeah. So that study that you're talking about is almost a quarter of a century old. That study was published in 1998. And it was, if I'm not mistaken, it was a 2-year study that followed 17,000 middle-aged, middle-income Americans. And they surveyed them on 10 questions about events that may have happened in their childhood between 0 and 18. And they asked about things like alcoholism, domestic violence, sexual, physical or emotional abuse, mental health or suicide in the family, incarceration, separation and divorce, which was a really surprising one. And the number of scores that you said yes to was what we called your ACE score, your Adverse Childhood Experience score. And the higher your score, the greater your risk was of developing cancer, diabetes, chronic pulmonary disorder, chronic fatigue, depression, and even engaging in addictive behaviors like smoking and alcoholism yourself. And so when that study was published a quarter of a century ago nearly, it was just like, oh, well, now what? Now how do we save the children? Forget the adults who already have high scores. Maybe there's something that we could do at the grassroots level with kids, and definitely programs have been implemented since then to help support kids and their caregivers. But more importantly, what I want to say is, yes, the emotional quality of our earliest attachment is perhaps the single most important influence on human development. And we as adults can develop new attachments as adults in the face of a history of adverse childhood experiences. That it's not that's it, this is fixed, this is your destiny. It's let's get curious about what happened so that we know how to help you. Because like you said before we pressed record, the nervous system is plastic. It can rewire itself. So when I had mentioned about that ventral vagal complex of the parasympathetic nervous system, the more frequently we can get ourselves into that state, the more we work on myelinating those parasympathetic nerves, namely the vagus nerve, and we see it after X number of weeks or months of stimulation that vagus nerve can actually grow. So this is a work of hope. This isn't the work of, this is your fate and nothing can be done. This work is about hope, where we get insights, and then we put patients in the driver's seat of their health by helping them become operators of their own nervous system. That's not my quote. That's another psychotherapist that has said it, Deb Dana, but becoming operators of your own nervous system.
I love that. And I like that you say that this is like a work of hope, because I always want, when people are listening to the podcast, like for one, one of my goals of this conversation was to shed light on how even the dysfunctional family relationships that you may have had in your past can have a lasting impact on the way that you see the world, and that will influence the way that your stress response sees a traffic jam. Right?
Yeah,
Or
exactly.
the project of your weight loss, or the,
Yeah,
going for the raise at work, like whatever, all these things that are so influential on health are being partly driven by the way that we feel about the stress, like bringing that stressor on of like, okay, I want to change. Right. And people, I think women
yes,
feel suffocated by the fact, like this feeling that they can't change, and they get into
yeah,
that perpetual self-blame that they're not capable of changing, when change, like accepting that change is a stressor, right? And so look at your health through
yeah,
the lens of like, well, like your nervous system is actually not prepared for this. Maybe your fish oil
that's
three
right.
times a week is a massive win,
Yeah,
that it can bring that level of compassion that we need women to have for them to keep going, right? Rather than looking at their health journey as this black and white, perfect or dumpster fire experience. But also, I want people to get
that's right.
curious about looking at the influence of their nervous system in their health. Because the difference between women we've worked with for years and women that we meet on day one, it's remarkable,
Yeah,
right?
it really is. Yeah, yeah. So what you're touching on is really, it's crucial here that when we tell them that we're going to help them to self-regulate, um, there's a few things that are going on here when we're teaching them to self-regulate. First of all, they're doing it in the caring witness of in our offices, right? So they get to be witnessed. And how many times have I had patients cry and apologize? I'm like, if you're going to ugly cry, this is the place to ugly cry, right? Let it out because it's already in there. It's just looking for an outlet. So this is a place to do it. And we're in such a position. I mean, what an honor to do the work that we're doing, where we can hold them in that space and give them the safety that they're longing for, to express the feelings that have been there for a very long time. And the other thing that I think is an element of building hope is that it doesn't require one more pill. Now, I acknowledge the value of prescriptions and supplements and dietary modification to support them foundationally. I mean, it's really hard to build resilience from an iron deficiency anemia state, right? So we have to support them there. And the work of the nervous system is not about giving them one more thing to take or one more thing to do. So in our office, and when I'm working with patients, is I give them really simple tools that help them settle, get grounded, and get into that ventral vagal parasympathetic nervous state that is a place where they can heal and repair and restore. And what you were talking about earlier is giving them credit for even having invited us into their circle of care. Giving credit and acknowledging their efforts is so important, because what this does is it raises the floor of how down they get on themselves when something in their day doesn't go right. So we want to reflect back to them, you got your fish oil in 2/3 of the time the last month. That's fantastic. That is a win. The fact that you've come to this visit, given how challenging the last weeks, months, year has been, that's a win. That is a sign of your resilience, your ability to know how to help yourself and bounce back. So those are the things that we want to be reflecting back to them, because that's coming from within.
Love it. And I'm
Yeah.
so grateful for the work that you do with our patients at Clarity Health, Dominika. How can our listeners find you?
Well, if they'd like, they can follow me on Instagram. My handle is Dr. Dominika ND, and then they can find me at Clarity
Awesome.
Health.
And we'll put the links to all of that in the show notes. And really like that
Yeah.
co-care model that we have with you helping support our patients inside the clinic is something that I'm really proud of, because it's really like, it's allowing our patients to heal like on all angles, and access the skills from practitioners that have a diverse skill set and interest. And I'm so grateful for you and on our team. So thank you for spending this time with me today. This was really, really helpful.
Thank you, Jordan. I'm so honored to have been a guest on your podcast today.
I hope you enjoyed that episode of Women's Health Unplugged. My goal is to help you feel more confident about your health. Please remember that what we talked about today in the podcast does not constitute medical advice, nor was a doctor-patient relationship formed. If you have questions about your healthcare or about how today's topic pertains to you, please take it up with your family doctor, your specialist, or someone on your health team.